All right. Good afternoon, and welcome back to another session here at the CRISP Summit. This session will cover non-CDS medications. And before I jump into introducing our speakers for this session, I did want to call out, someone mentioned in the chat they weren't able to retake the survey that we've been promoting at the end of each of these. We fixed that issue, so you should be able to retake the survey, and appreciate your calling that out and continued feedback. We are recording this session, and we will share the recording and the slides with everyone in an email after the conclusion of the summit. And if you have any questions as our speakers are going through their presentation, feel free to put it into the Q&A feature, and we should have some time at the end to answer some of your questions. I did want to kind of cover, we have created a new page specifically for our work around non-CDS medications on our website. Here you can find a little bit more background about what our speakers are going to be speaking about today. And as this process unfolds, we'll be continuously updating this page with more information so that you can always find the correct documentation for this project. All right, so that leads me into our session today on non-CDS medications. I want to introduce our speakers. First, from CRISP, we have Maya Gottlieb, who's a behavioral health lead. And then from MHCC, we have Anna Gribble, who's assistant division chief. So I will turn it over to Anna now.
Great. Thank you, Kevin, and good afternoon, everyone. So as Kevin mentioned, my name is Anna Gribble, and I'm the Assistant Division Chief in the Center for Health Information Technology and Innovative Care Delivery with the Maryland Healthcare Commission. And I'm very excited to share with you today this really interesting project that the MHCC has been working on with CRISP. Next slide. So as I mentioned, I'm with the Maryland Healthcare Commission, or MHCC. And for those who are not familiar, the MHCC is an independent regulatory agency whose mission is to plan for health system needs, promote informed decision-making, increase accountability, and improve access in a rapidly changing healthcare environment. The MHCC supports various programs and initiatives that aim to diffuse health information technology statewide. And these programs and initiatives are often in response to stakeholder needs or the implementation of legislation passed by the General Assembly. The MHCC is also tasked with identifying a state-designated health information exchange, and CRISP has served in this role for many years, and the MHCC works closely with CRISP to implement innovative policy initiatives. Next slide, please. So moving on to today's topic, medication errors rank as the most frequent and avoidable source of patient. Adverse drug events cause more than 1.5 million emergency department visits annually across the country, and an estimated 44 to 98,000 hospital visits are attributed to preventable adverse drug events. Medical costs for treating drug-related injuries occurring in hospitals amount to 3.5 billion a year, and that's not even accounting for lost wages or productivity. And as many of those on this call know, incomplete medical records can have far-reaching consequences, including misdiagnosis or inappropriate treatment, delays in care, or patient safety concerns. Next slide, please. So in response to this real healthcare quality issue, the General Assembly passed Chapter 296, House Bill 1127, which is the Public Health State Designated Exchange Health Data Utility. And this law aims to improve access to comprehensive medication histories for pharmacists and prescribers to support informed treatment and dispensing decisions. The law does this by requiring dispensers to submit information on non-controlled prescription drugs, or non-CDS, dispensed in or into Maryland to CRISP. The non-CDS data will be made available for public health and quality improvement purposes and treatment and care coordination of a patient for authorized users of CRISP. The use cases specifically identified in the law include antibiotic stewardship efforts and the promotion of health equity and treatment efficacy, but I'm sure everyone on this call can think of several interesting public health use cases for this data, in addition to it being incredibly valuable for healthcare providers. Next slide, please. So moving on to implementation of the law. Comar 102518 Health Information Exchanges Privacy and Security of Protected Health Information is the regulatory framework to support implementation of Chapter 296. Stakeholder input guided development of the regulations through informal and formal public comments and working sessions. And final regulations were approved during the March Commission meeting and published in the Maryland Register on April 4th with an effective date of April 14th, 2025. The regulations require dispensers to begin reporting non-CDS dispense information to CRIS by September 1st, 2025. Next slide, please. So as I've mentioned, medication discrepancies and adverse drug events pose significant challenges to patient safety and the delivery of high quality care. Now, the Maryland Prescription Drug Monitoring Program, or PDMP, makes dispense information for controlled dangerous substances available. And this data is available to assist providers with care delivery and clinical decision-making, as well as public health and safety authorities with reducing the misuse, abuse, diversion of controlled drugs. So expanding access to a more complete patient medication history by adding in information on non-CDS dispenses will support care delivery in many of our shared public health goals. Next slide, please. So to prepare dispensers to begin reporting this additional dispense data, the MHCC released a non-controlled prescription drug dispenser data submission manual. The manual provides technical guidance to dispensers in alignment with the PDMP submission process for controlled dangerous substances. The regulations required the dispenser manual to align to the extent possible with the Maryland PDMP data submitter user guide and must specify the data that must be submitted to CRISP and in what format, the time frame and frequency of data submission, the electronic reporting specifications, as well as the processes for dispensers who are unable to submit data due to mechanical, electrical, or any other failure. Next slide. So I recommend those who are on this call who will be reporting data to take time and review the manual, but this slide provides a high-level summary of the main points. So I've used during this presentation the identifier dispenser a few times. So a dispenser means a person authorized by law to dispense non-CDS prescription drugs to a patient or a patient's agent in or into Maryland. Dispensers will report to the RxGov platform, and the data must be submitted in the same ASAP format that the PDMP requires. Now, we're very excited that dispensers will be able to submit one file with dispense information for both controlled dangerous substances and non-CDS drugs to reduce burden. And finally, dispensers must minimally report non-CDS dispense information daily, including the submission of a zero report on days when no prescriptions were dispensed. Dispense information should be reported no later than the end of the next business day after the prescription is sold, and data are encouraged to be reported as close to real time as possible. Now, in the manual in Appendix A, there's a list of the required and optional fields for those who are interested. Next slide. Just a little bit more information about the manual, and then I'm going to hand it over to Maya, but a multi-stakeholder approach guided the iterative development of this guide. It included preliminary planning with the non-controlled prescription drugs work group, and many stakeholders reviewed and provided feedback on informal drafts of the dispenser manual in summer and fall of 2024, and then as recently as spring of 2025. The manual was published on May 2nd in the Maryland Register, and the MHCC is accepting public comments through May 22nd. And in preparation for the September 1st reporting timeline, the MHCC will continue to partner with CRISP and others to inform dispensers of this upcoming reporting requirement. Next slide. So thank you so much for allowing me to share the MHCC side of working with CRISP on this really exciting project. I've provided contact information and a QR code to our website. I think the website was also included in the chat. But I'm happy to answer questions maybe after Maya's presentation, as she may provide a little bit more detail to this process. So I'm going to hand it over to Maya now.
Thanks. Actually, Kevin, would you mind if I presented? I think this slide deck may be a bit outdated. Mhm. Okay, this work? Everyone see this? Okay, great.
Yeah, we can see you.
Okay. So I'm just going to go ahead and share a bit about non-controlled medications and CRISP's role. Anna's done a great job of outlining kind of where this comes from and how NHCC is preparing for this. And I'm going to share a bit more about what CRISP is doing. So CRISP's role is the designated health information exchange and health data utility. We are responsible for collecting the non-controlled medication data. So that's our job. And per our policy, in order to accept this data, folks who are submitting data will have to sign an agreement with us. This is kind of standard for folks who have already submitted any other kind of data to us, any other kind of clinical data to us, but perhaps new for people who have submitted PDMP data, which doesn't require this. But there are two options for these kinds of agreements. There's the standard participation agreement, which again, you may be familiar with if your organization is already sharing data with CRISP, and then the connection agreement. And I will share a bit more about each. So the participation agreement is a standard CSS agreement, allows users who are covered under that agreement to have clinical access, which means access to clinical data, which would include this medication data. It does require a panel, so you would have to share which patients are in your panel to see data on them. And we are developing an automation process so we can create a panel for pharmacies, which are kind of a new type of industry who have clinical access. The other option is a connection agreement. This is a newer agreement type, which allows for dispensers to submit data to CRISP, but it doesn't allow visibility. It's kind of a lower commitment. But again, it's required for anyone submitting data as part of this process. But users will be able to see their own data that they've submitted through the portal that they're using and correct errors. One important thing to note is that if a dispenser receives a waiver from MHCC, therefore they're not submitting data, they don't need an agreement with us. So going a bit more into the submission process, as Anna said, per law, and just to make it easier on dispensers, we're trying to align non-CDS medication submission as closely as possible with CDS submission, which is PDMP submission. So dispensers will be able to use one file only, so they won't have to create a separate file. They'll just have to add non-CDS medication data to that file, and they'll submit it through the existing portal we have with our vendor, RxGov. And they can submit it through the existing submission method that they're using, which would be either SFTP, we offer file upload, or a manual entry, and the existing submission format that's being used for the PDMP, again, to align. So that's outlined here, the 4.2a, 4.2b, and 5.0 currently accepted. 5.0, I know most folks aren't using yet, but in the future, we're ready to receive it. And in addition, there's no additional registration for current dispensers. If you've already registered to submit data with RxGov, you don't need to do it again. If you're new to this process, you will have to register so we can set up your account. And then a few other differences. So the way it works is that because folks will be submitting one file often, the portal itself will be separating the data based on NDC number, which is the number assigned to each dispense. And then once separated, the two groups of medications will be subject to different validation rules. And I think a good example of this is that if you're dispensing a non-controlled dispense, you can dispense it just with an MPI. That's obviously not true for controlled substances. So things like that. And as Anna said, the dispenser manual has a lot more detail on required fields and things like that. And then if there are errors in dispenses, manual error correction will be done separately. So if you're submitting both PDMP and non-controlled data, you would update your errors separately. You are also able to simply submit a new file that overwrites the old file. And that's another option for correcting errors. And then, as I said, new reporting dispensers will have to register in the submission portal. Okay. Okay, next, I wanted to talk a bit about accessing the data. I've talked a bit about how this data would be similar to other clinical data in that we're requiring an agreement. This is an important distinction from PDMP, that although the data is submitted through the same method, it's visible to different folks. So because this is clinical data, only clinical CRISP users will be able to see the dispensed medication data. And they'll only be able to see it for users on their panel. I've already said this is not PDMP data, it will be displayed in permission separately. That said, for folks used to using CRISP to look at PDMP data, it'll be right next door. So it'll be right under medication management and you'll be able to see the data there. I have a quick mock-up and this is subject to change. So let me just show you kind of, again, very similar look to PDMP, but you can see how the medication has been dispensed. And then also we'll be grouping medication data so that if someone gets a daily prescription, you don't have to see every single day. You can unfold that and see, okay, if you want to see more information about the dates of dispense, you can see that, but otherwise you'll only see distinct medications. And again, this is a mock-up. So Anna outlined some of these benefits to what we're doing here, but I did just kind of want to reiterate that I think this data will be incredibly helpful. It's more comprehensive than other clinical medication data, I should say, that we have access to right now, because it's coming straight from dispensers. So it'll really be kind of the full picture of what actually gets provided to patients. And kind of on that front, it's more accurate than patient-reported data, through no fault of the patient. They often just don't know the details about their medication history. And so this will be much more specific and accurate. And then in addition, we have claims data often for medication data, but that takes time to come through. So this way, it's going to be a daily reporting requirement. And so you'll be able to see data immediately the day after. And then kind of as I just went over, you'll be able to see changes to medications over time. So if a prescription changes in dose or, from a generic to a non-generic, you'll be able to see that. Just to end here, if you want to begin onboarding, if you're a dispenser, we're conducting proactive outreach to most dispensers if we haven't started already, over the next few months, we certainly will be. But if you'd like to begin onboarding, you can certainly contact us and get that started. And then myself and my coworker Alicia are here for any specific questions about the onboarding process. So thank you.
Thanks so much, Maya, and thank you, Anna. I now will open it up to questions. So if you have a question, feel free to put it in the Q&A feature, and hopefully we can answer them here. So the first one is kind of what patient population is this for? I guess who are we receiving non-CDS medications from?
I can share, and then Mike can jump in about we can access potentially through CRISP. But so the requirements for dispensers to report all non-CDS dispenses in Maryland. So this will be for anyone who is receiving medications from an authorized dispenser in the state. And Maya, the question may be specific to who within CRISP who has access to the dispense information. If you could share a little bit about that. You mentioned it before, that those who are authorized users of CRISP will have access to the dispense information.
Yeah, I'm having a little trouble hearing you for some reason, Anna. But just to kind of, I think, reiterate what you said, it will be for all medication that's dispensed for folks who are subject to the law, so who are kind of an outpatient pharmacy receiving this medication, and then users, again, will be clinical users. So that hopefully that answers that question about kind of the patient population.
Yeah, thanks. We had a similar question about over-the-counter medications. That's not part of this.
try again, and then hopefully my audio is better. Does it sound better when I come in?
Sounds a little bit better. You're still a little bit echoey, but I can hear you.
I'm sorry about that, everyone. If you can't hear my answer, feel free to reach out to me directly. I'll do my best. I apologize. So correct. The over-the-counter or the supplements are not required to be reported in this requirement. It is a really interesting question, and I completely understand where the individual is coming from who asked this question. It's definitely something for us to take back and consider, but those will not be, it's any dispense of a medication.
Thanks, Anna. Someone's asking a question about confidentiality. How do we suppress prescriptions being dispensed to adolescents to protect their confidentiality? Has there been any thought about that in CRISP?
I can speak to the first part of that question that I see, which is about just reproductive health, which is just that this will be subject to the same laws as any other clinical data about reproductive health, and CRISP is working on requiring consent for any of that information. As to the other information, I'm not sure I have a great answer for that, but we can certainly get back to you.
Yeah, thanks, Maya. If you stay tuned to our next session at 2:30, we're talking all about sensitive data. So you can hear about the laws germane to that and the consent process at CRISP. So thanks. Are any of the regional HIEs likely to have this data anytime soon?
I know that Connecticut is kind of working on getting some of this data, but Maryland is definitely a first mover. We're happy that MHCC is really moving forward with this. I think it'll be kind of an exciting, I don't want to say experiment, but a project to allow users to see this data and hopefully prove how helpful and important it is for clinical care.
What do you anticipate the process will be for, I guess, testing and before we turn this on live in the InContext platform?
There will be a lot of testing. I am certainly part of that. We're testing the platform itself. We're testing the ingestion of the data. We're testing the display of the data. We're going to work with dispensers to make sure that they're sending the data and it's coming through. So I don't want to go ahead and detail all of that, but just that there is a lot.
Perfect. Someone says, I am a pharmacist practicing in a clinic and have several questions. I'm wondering how the non-CDS data is different than the current PBM reported dispensing data.
There may be some differences. I'm not as familiar with the current PBM reported dispensing data. So I'm not sure exactly, how to answer that. I think the manual outlines what data will be included. So that's probably the best place to look for that.
Will the system record whether the patient has picked up the medication that was dispensed?
I think we're only recording dispense date and date written right now. I think that, dispensed is much closer than obviously, just was the dispense written, right, or prescribed. So we're getting as close as we possibly can to that. But I don't believe that we, I think that to this point, actually, dispensed does mean that it was provided to the patient. Filled is the other date. So a prescription may be filled and not dispensed. And that happens sometimes. We'll be collecting that information too. But yes, so we will know if it was dispensed, i.e. provided to the patient.
Awesome. Someone asked, are health departments subject to this requirement?
Health departments are subject to this requirement. I encourage them to reach out to me directly for questions about this. We understand that this may be a new reporting requirement for many dispensers who may not be dispensing controlled dangerous substances.
There is a provision in the regulations that allows dispensers to request a time-limited waiver to this process. And we are working on that waiver request form now. So we hope to have that on our website soon, but for other questions, I've received questions from other local health departments as well. Please feel free to reach out to me directly.
Awesome. Thanks, Anna. We have a lot of questions. I'm hoping we can get through it. We have 5 more minutes, but any that we can't answer, we will follow up offline. Will dispenses from VA hospital pharmacies be included?
So that it kind of goes to right now if the pharmacies request a waiver or not. So any authorized dispenser in the state, according to the law and the regulations, is required to report. But it's a good question, and we're following up with others on the federal agencies who may be subject to this requirement and if they will be reporting or not. So more information to come.
For non-CDS, does this apply for samples provided to patients?
No, this does not apply to samples.
Because this information is interfaced with CRISP, is it only dispenses in Maryland? Are there any other states included?
Yeah, it's dispenses, as Anna said, in or into Maryland. So and I think there's another question about mail order pharmacies. If you're dispensing into Maryland, then you're subject to it. If not, not.
Will there still be the ability to manually add some supplement info if it's known to the provider?
Any ability that you have is not being taken away. I'm not familiar with that, but this would just be new information that hasn't previously been there.
Will the original prescription be recorded, or is it just the generic substitution made at the pharmacy when the patient picks up the prescription?
It's whatever the pharmacy dispenses. So if they dispense the generic, that's what would be on the dispense information.
For non-CDS reporting, is this required for agencies that receive patient injection medication from pharmacies to dispense or inject patients?
Right.
I don't know if I read that right.
Yeah. So injections would be probably considered a medication that's administered to a patient. So the requirement is specific to medications that are dispensed, and there is a specific definition and statute of dispense that's separate from administered. So I'm happy to share those definitions with you.
Does this include any specialty pharmacies like those which may be affiliated with healthcare systems?
It's inclusive of some specialty pharmacies. The definition of dispenser does have some exclusions, which are the same exclusions that are for the prescription drug monitoring program. So please reach out to me directly and I can clarify which dispensers are included in the definition.
Someone asked, did you cover how to use the data for quality improvement, which is allowed by the regulation? So in the regulations, there's going to be a time period of collecting the dispense data before CRISP is going to be making it available. And so we will be working with CRISP on their process for making the information available. So more information to come.
Oh, I should have mentioned that in my presentation. So thanks for bringing that up, Anna. Yes, there will be a few months between the September 1 date and when the data is live, potentially for viewable. We will keep you posted on that. But in terms of quality improvement, also I would say, we'll work with pharmacies and dispensers to make sure that their data is coming through as correctly as possible, that they're submitting it as they're supposed to be, et cetera, et cetera. I'm not sure exactly what you meant by quality improvement, but hopefully that addresses it. All right, Anna and Maya, thank you so much for your presentation. Obviously, we had a lot of questions and there'll be more to come as we get closer to September 1.
and we start collecting some of that data. So thank you. And if we couldn't answer your question now, we will follow up after this.